But I'm Jody Platt. I'm the co-chair of the Mobilizing Computable Biomedical Knowledge Working Group on Trust and Policy with Blackford Middleton. And Josh Richardson, who will give us a talk in a moment about trust in a, I don't know, complementary initiative from CDS Connect, is also a leader in this program. We will hold questions until after Josh is done, but you can start sending them in anytime through the chat button at the bottom of your screen. And hopefully we'll have some good discussion going. I think this is a really interesting topic and is a fun one to talk about. So you can find your chat button now and just start playing with it, and we'll get your questions later. So Josh Richardson is at RTI. He has a background in clinical informatics and health information technology and information science, and has done all kinds of work in evaluating health IT and data, and is a real expert in his field. So he's going to talk about addressing trust in clinical decision support and knowledge artifacts, clinical decision support being one of the major examples of computable biomedical knowledge that's out in the world and on the market today. And I think that's the major introductory bit at this part. Josh, if you want to take over and tell us what you're going to talk about, I'm really looking forward to it.
Well, thanks, Jody, and thanks all for joining today. I'm very excited to present the work that I conducted and with Jody, Blackford Middleton, Barry Blumenfeld, and quite a few other experts who we're indebted to for their volunteer efforts in helping us take on what I think was a very interesting project, and I think you'll agree that it's resulting in some really interesting products, most specifically ways in which trust is being operationalized for a CDS repository which is CDS Connect, and we will certainly get into that. Just so that I'm clear in terms of being able to move slides forward and backwards, I'm not seeing the controls that were described prior to this call. Can somebody just give me a quick pointer?
Sure, Josh, this is Mary Jo. Right, okay, so if you're looking at the screen, to the far left, you should see, and it's white, so it may not be really clear, but you still should be able to see it, a white elliptical bar that has a number in it. I don't know what number it's on right now. It should be on number 3. Yep. If you go down here, it moves it forward.
All right. Okay. So our next presentation can be on human-centered design. But thank you for showing me that. I got it. Before going into thanks, Mary Jo. So before going into today's presentation, we just want to put out a few acknowledgments. First is the funding through a cooperative agreement from the Agency for Healthcare Research and Quality. It has provided 4-year funding for this cooperative agreement, that being the Patient-Centered Clinical Decision Support Learning Network. And it was the Patient-Centered CDS Learning Network that brought together various stakeholders together to do this work within a trust framework working group. The URL that you have there, we recommend, or we encourage all of you to check out what's going on at the Learning Network. We have a resource center, and we've also put out most recently an opioid action plan for patient-centered clinical decision support, which includes use cases and recommendations from quite an array of stakeholders, from vendors to content developers to patients and providers. The work that we're presenting today resulted in a white paper that's also on that website, where we have a peer review manuscript that's still under review. So hopefully we have that with some additional content beyond the white paper. And I would like to acknowledge, it's not on screen, but certainly the partnership from MITRE, which runs CDS Connect. They were involved in the work group, and it's been wonderful working with them and getting feedback from the working group, which we certainly did while putting together the methods and results from this work on trust. So just laying out an agenda of today's presentation. Just a brief background why trust is necessary for clinical decision support and more broadly computable biomedical knowledge. The methods that we used, which was really a role and relationship-based approach informed by Dr. Jody Platt, and what that resulted in terms of who makes up the ecosystem for which 9 trust attributes applied, out of which we developed 33 recommendations. Along the way, I'll note where those recommendations are actually being put into practice by CDS Connect, and that's an exciting outcome. Some larger takeaways, and then we should have some time at the end for questions and discussion. So just to provide a larger frame as to how and why we came upon this work, and that is the CDS Connect project, which is funded by ARC and being developed by MITRE. So our CDS Connect provides both an authoring tool and a repository within which there's shareable clinical decision support. And out of this, if you will, an online library is how I view it, of clinical decision support artifacts. From it, end users or end institutions towards the end of the value chain can download and implement these artifacts, albeit with some additional tailoring to their local institutions' requirements, primarily via their EHR. So if we move from left to right and we look at the chain in which evidence can move from a narrative guideline, which I think we've all seen, and say in the form of a systematic review or a meta-analysis write-up or even a clinical practice guideline, that's great for human reading or readability, but there's not much that a machine can do. So in order to make it machine interpretable, we need to transform that narrative into varying levels of sophistication. And one way is, or framework that's well known to us in the CDS community is the Boxwala et al. Model, in which there are 4 levels of transformation. So we could, for example, in this case, transform that narrative into something that's more structured, and it makes logical sense, such as transform that, if you will, into a knowledge artifact, say by clinical quality language or CQL. That's what knowledge artifacts, that's how they're structured within CDS Connect, which is the big screenshot there. If you're not familiar with CDS Connect, it provides a way for people, developers, providers, those who are interested in transforming and translating guidelines into these knowledge artifacts, storing them within this repository from which artifacts could be downloaded and implemented. So if we go to the far right of the slide, they can be implemented, say, within hospitals, or if we look in the future, maybe even directly downloaded to patient smartphones. So that, and from usage of these artifacts, ideally, there's a feedback loop in terms of what artifacts were downloaded, the degree to which they were used, maybe how satisfied end users may be or not be. And that feedback circles back into the CDS Connect repository. We could even extend those arrows further from right to left, because we want that feedback ideally to inform the idea, ideally how the knowledge artifact has been translated, and even further to the left, what guidelines may need, how guidelines may need to be updated based on real-world data, real-world evidence. So it's in one way, this is a great illustration of a learning healthcare system. However, along the lines of this value change, both left to right and right to left, oops, I have to use this over here. I think you can understand why or how there may be challenges around or issues of trust. So from the far left, how do we trust that a guideline went through that transformation process in a reliable manner? Who made the translation? How are future translations to be maintained? Similar questions we could ask as the knowledge artifact goes from CQL into the repository, issues, say, around intellectual property, indemnification, what have you. And then on the far right, trust around who's using it, what is the kind of feedback that they're providing, is that feedback trustable, and trustable enough to make changes or force changes back within the repository, again, going backwards from right to left. So it was with this trust issue that we as a working group set out to try and explicitly address what within a knowledge artifact or a clinical decision support artifact ecosystem, assuming there are all of these a world where there's all of these artifacts floating around, how do we know how are we going to know which of these artifacts are trustable? How do we ensure that they're trustable? And I think when it gets really interesting is some of the conversations that they're leading, how do we know when decision support driven by artificial intelligence is trustable? Who is, and how is that managed? What is the governance structure and the standards and regulations of knowledge over time? Oops, sorry. I keep hitting the wrong button. So what I laid out or tried to lay out for us is that a learning health ecosystem for clinical decision support, and by extension, computable biomedical knowledge, will have to balance diverse stakeholders' goals and provide reasonable constraints for action, particularly around content creation and management, implementing, sustaining clinical care, and sustaining stakeholders' trust through good or effective governance. And there's emerging literature that tackles trust from an ethical standpoint, but also also looking at what ethical and trustable architectures look like, and how we can, within governance in legal structures, address CDS governance. So Hongster-Meyer et al., for example, noted from the experience of the CDS consortium, challenges and solutions that they developed for sharing knowledge around intellectual property, liability, and who has sign-off authority within participating organizations. Faden et al. Also approached this from a learning health system ethics framework. So I think that one of their facets from the framework talk about how CDS can fit and ethically be addressed within a continuous learning activity that improves the quality of clinical care and healthcare systems that are directed really at multiple parties: researchers, clinicians, administrators, payers, and purchasers. And with some of this background that informed the approach that we took for our work, and I'll describe in a moment. And as I stated, I think what the Learning Network and what CDS Connect and HSPC and others are looking at, the distribution, updating, and verifying reliability of decision support provides one of many special cases of computable biomedical knowledge where there has to be some trust fabric where within this ecosystem people feel that they can trust the knowledge, which I might want to note we see is somewhat different from data. And maybe we'll get into that in the slides ahead. So the way that we approach this is we chartered ourselves to it by addressing some issues based on work done by the Learning Network and the Analytic Framework for Action. We have found the AFA to be a helpful way of bringing together multiple stakeholders to conceptualize, provide a common mental model as to the many steps that go on through knowledge translation, implementation, evaluation, and ultimately contributing to a learning health system. So on the outside, governance, marketplace, policy, and legal, we saw this as really the aspects of the AFA that the Trust Framework Working Group would focus on. Other items within the cycle, authoring, implementing, prioritizing, these were carried out by other working groups. two key deliverables from the Trust Framework work group were use cases to identify barriers and facilitators for what we saw as operationalizing a trust framework, and then secondly, a white paper that would be generalized and ideally used by end users and put into practice. And so I'm very happy to say that CDS Connect has been able to do some of that, which we'll get into as we go through the results. So I just want to make a big thank you to those who volunteered for the TFWG. I think, as you see, it's a fantastic group of informaticians and researchers and a patient advocate, all from various organizations that represent a broad array of stakeholders, a payer to an implementer to a policymaker to evaluators and so forth. So thank you to all those who participated in the work group. In order to try and ground ourselves, we worked from 3 scenarios for trust and clinical decision support that emerged from CDS Connect's own experience, where we had 3 scenarios where there was a contributor to the CDS Connect who wanted, so CDS Connect was wondering how did they ensure the integrity of the contributor's metadata and what their coding was for the artifact. Another scenario is how it really gets to findability. If there are 2 similar artifacts, one that's been piloted and the other is not, how does an end user determine one is more trustworthy and why? Another scenario, if there's a quality improvement manager who wants to implement a checklist, but wants to know what others have downloaded similarly, and what might those experiences have been. We thought that these were interesting scenarios, and so we used this as a framing device to help us work as a group of volunteers and structures the conversations. So I'll briefly go through the methods. I basically carried out our work in 4 major phases. Research by who's done work in this area, and here hats off to Jody Platt for level setting the group and really introducing us to trust and how it plays out in not only the healthcare domain, but how other industries are having to address trust. The roles, relationships out of which the interactions of roles and relationships and the very competing and complementary needs informed recommendations. So more specifically, what I laid out there in the 4 steps, you can see some of the sub-steps that we did. We had internal surveys. We presented to one another. We carried out a matrix exercise, all of which is many of these materials are in the appendix, so you can have access to them, and also happy to get into more detail during the Q&A or offline. So to go through the results, one of the areas that we wanted, the method that we used was to really understand who are the players, and so the roles, and then what are the relationships among them. And out of this, we hope to, and we did develop attributes of trust within and recommendations based on those attributes. So we as a group agreed that there were 12 actors. These include patients and clinicians. There are also those on the knowledge side, those who author or do that translation process that I described earlier in the overview slide. Those who implement that knowledge, those who update knowledge as it goes. There are vendors and societies who distribute knowledge, IT vendors that put it into clinical workflows. And you can kind of go around, you can see that all of those, or within an organization, there's a governance body that also has to monitor and sign off on whatever gets put into practice. Policymakers, payers, quality improvement analysts who also are key to evaluation and monitoring the effectiveness of any CDS implementation, as well as population health end users. And this is a role in which the group felt they should be called out separately as a particular use case, one in which decision support is not as a point of care, but rather looking for panels of patients, and that these users have particular needs that should be addressed or at least accounted for within the recommendations. Without going through all the sausage making, I'll just go straight to the main course, and that is the 9 trust attributes that we develop. And it's out of these 9 trust attributes that we have 33 recommendations, and I'll go through those briefly in the results. But the 9 trust attributes we have are competency, compliance, consistency, discoverability and accessibility, the evidence-based feedback and updating, organizational capacity, patient-centeredness, and transparency. And as I go through the results, or the recommendations, I'll point out at places where CDS Connect, as of January 2019, was either putting into effect that recommendation or had deemed it something of interest but had to be tabled or out of scope. So by looking at competency, and there was a lot of back and forth, not only about the attributes, but how we define them, was competency of those who are contributing artifacts to a centralized repository, and that there may need to be some way in which repository managers can gauge that somebody is competent or informed enough about adding knowledge to a repository that is reliable, and that is valid. So example that we provided is that they should be competent, qualified, and appropriate authority to develop the artifact based on factors such as past performance, professional qualifications, or certifications. And I don't mean to gloss over that, but I think you'd agree that with that there's a lot of design considerations that would fall out from that one example. So we provided recommendations within each of the trust attributes, and I won't go through each and every one, but there are these are all recommendations that CDS Connect has considered, and I'll call out those that they've moved forward with, and others that they're tabling for the time being, and certainly there could be updates between what info I have on that from January until now, but I'll lay them out for you nonetheless. So recommendations 1.3 and 1.4, for example, CDS Connect, thought that these were out of scope, although still that they would be very interested in thinking about how would we go about credentialing authors. One example could be looking at Cochrane crowds and how they credential end users to vet and contribute their knowledge from a review. They teach them how to review systematic reviews, and then copy, paste out tables or pull out what would be salient data, and are certified those end users along the way. That could be one example of how there could be a scalable way of credentialing authors and knowledge professionals to gauge competency. A second trust attribute is looking at compliance and a knowledge artifact, how it should conform to defined standards and criteria, and these include copyright and intellectual property. And so how these comply include having both human-readable and machine-readable forms, knowledge artifacts that comply with best practices for safe and effective implementation, and artifacts that are encoded using current standards for controlled medical terminologies, value sets, and data models, and knowledge representation formalisms. Third attribute is consistency in how a knowledge artifact should repeatedly generate expected results over time when given requisite inputs. And so those inputs could be patient data or supporting CDS triggers, such as, for example, too many alerts. And so for that reason, having to maybe tweaking that CDS artifact to reduce the number of triggers. The recommendation we have for the consistency is the authors take on the responsibility of ensuring accurate knowledge translation, specification of knowledge of a knowledge artifact. And so how to operationalize that in terms of maintaining and ensuring that the results from any artifact is consistent over time, I think it would be a real challenge, and it's one that don't have the solution for. And so, but we put it out there as a group. This is a really key piece of ensuring trustability or establishing trustability within a knowledge artifact. So I found this discoverability and accessibility as an interesting attribute of trust. The ability of an end user to develop trust in a tool by essentially being able to use it and feeling like they use it effectively. And that is, and in this case, how do they discover, how do they find knowledge and access the kinds of information that they want or need before deciding to implement it, say, within their hospital or downloading it to a smartphone. So the evidence behind an executable artifact is documented, is discoverable from the metadata associated with the artifact. Artifacts and their contents have clear and appropriate reasoning for recommendations available to end users, and they're accessible to potential end users, including patients and policymakers. And so when looking at discoverability and accessibility, 4.2, for example, is something that was already available within or available to a large degree within CDS Connect. There was a search interface, and they were and CDS Connect was tagging artifacts with keywords. I think those were based on mesh subject headings, but don't quote me on that. And so I think it's a fantastic piece to added functionality of CDS Connect. What they had as of January 29 noted something to be put in development is making that accessible through search technology in conjunction with effective and helpful key terms. So enhancing the discoverability and accessibility of knowledge, I think is going to be a key. I think many agree this is a key function that CDS Connect will need to build out as hopefully more and more artifacts make their way into that repository. So I think it goes without saying that we want artifacts to be evidence-based. And so that evidence that's instantiated within an artifact must apply to the clinical condition that is meant to support. And this should be actually easy to say, but it's difficult to put into action because as say CDS Connect or a vendor, how the artifacts are to be used, especially if they go out to, say, direct to consumers, how they're being used or potentially misused. What is the governance that goes over that and accounts for any potential liability or and so forth. So limitations we think need to be stated clearly. There needs to be evidence around the clinical guideline, predictive model, if we started going forward with AI, in an artifact that is substantiated in its clear appropriateness. And so the kinds of metadata that would be recommended, and I think it's probably what's happening a lot on the technical side of the MCBK community, is what are the kinds of metadata that could or should be included as it relates to enhancing trust. And so these 5 recommendations are what we included. And I think I would be interested to hear if anyone from the technical group is on the call, how these align or align with what you're thinking for MCBK-based metadata. Another aspect, attribute of trusting for CDS artifacts, ways in which there's feedback and updating of those artifacts, and that stakeholders have the functional ability to provide timely feedback and suggest improvements to a knowledge artifact. And that feedback can be directed to various actors in an ecosystem, which, as we covered from a previous slide, can be a whole host of stakeholders, including knowledge implementers, engineers, authors, patients, providers, payers, and so forth. And so we've had quite a 6 recommendations here, one of which, as of January 29, seems to be being put into operation within CDS Connect 6.2. That I think MITRE is still working on and considering how to put in place some kind of feedback mechanism by which users can ask questions about an artifact's context, the context of its use. 6.5 is an example of one that seems reasonable to do. However, it's in the parking lot, and so I'm not sure if it's going to be gone. We're going to get to it within 2019. But that the idea that to enhance trust, artifacts should be based in part on the feedback and from operational performance over time. Attribute 7 I think is interesting because it looks at how do you trust trustability from an organizational perspective. And does the organization that sponsors a knowledge artifact development or implements that artifact or both have the necessary funding, staffing, and resources to maintain a knowledge artifact and measure its effects? So from what was coming from the discussions is that it's much more likely to trust an artifact if it knows that, or there's some there's knowledge about that artifact coming from an organization that has the resources to ensure critical quality control and ensure timeliness and recency of its knowledge. I think this was, if I recall correctly, was strongly advocated for by one of our providers in the group. It's just some way of being able to convey through a tool and convey that there's skills development and that that organization that developed or contributes a knowledge artifact has the staff, the systems, and the resources to support implementation. And that they also include the implementation guidance that conveys the kinds of resources, oftentimes that can be substantial, to implement that artifact. And so organizational capacity. So we're coming close to the end. We have 2 more. Patient-centeredness, so that an all-knowledge artifact should, whenever possible, leverage patient-centered outcome research findings or patient-specific information. That idea of using patient-specific data, patient-generated health data, PROs, to support decisions by those patients and their approved caregivers and care teams. So I think this attribute is really being more forward-looking and thinking about ways in which knowledge generated from some of the more Fitbits and Apple HealthKit and others how we begin to trust artifacts that are developed out of these user-based data sources or out of users who contribute their data. So requirements for patient-level generated data input are clearly indicated, evidence that it counts for patient-level or patient-generated data, and consent. Lastly is transparency. The knowledge artifact should be applied and used ethically, clearly convey all potential conflicts of interest and disclosures of interest related to its development or recommendations so to detect bias or discrimination in its use. (9.2), for example, as of January 19, is in development within CDS Connect. So clearly indicating the policies and how those policies address conflicts of interest. Other recommendations, policies that describe the procedures for implementing, updating, revising, and removing artifacts, how artifacts are consistently implemented with licensing agreements, and knowledge artifacts implemented in ways that support equity in health and healthcare. Just to discuss where we've gone since then. So, in applying what the recommendations to back to the AFA, which looks at how to prioritize evidence, author, implement, and measure the effects of evidence within clinical decision support, we had some general thoughts around the ways in which these could be carried out. So, a formal evidence rating system for decision support or and/or computable biomedical knowledge to help end users identify ways to prioritize what's the guideline or practice guideline or systematic review to be put into practice and apply evidence within the context at hand with whatever unique patient data may be available. Thinking about authoring interventions. So how can trust account for deviations from guideline logic? And by clearly noting those deviations within the artifact and having those deviations maybe track with the artifact over time so that there's an evidence trail or a provenance of that artifact and a means to capture that as evidence moves forward in time and maybe is shared and altered by different organizations, some of which may want to continue or contribute to a larger generalizable knowledge, others that may make institution-specific changes in order to meet particular clinical workflows or specific organizational requirements. Thoughts around trust with implementing, and so thinking about how organizations require that capacity to safely and effectively implement CDS, computable biomedical knowledge, and what are mechanisms by which that can be conveyed, not only back to the organization in terms of what kinds of resources it has in relation to any knowledge that wants to be implemented, but how that can be shared with others within a community that want to exchange knowledge, sharing best practices for implementing the specific artifacts, and make implementation details fully transparent. And so we think that there's still much more work as to how to instill feedback at multiple levels, to knowledge authors as well as to patients. So who's used an artifact to date? And how often? What were any known limitations? Much thinking about when you get a medication and you have your and then you have all that literature that goes along with that medication. What are some of the known side effects that might come with, in this case, a knowledge artifact, just with the medication, so that there's transparency and that the end user is fully informed before either implementing it within their hospital or putting it or downloading it and using it on a smartphone. So although we I'm really excited to be presenting these results. There certainly are some limitations to the approach that we use. So it was a volunteer group, and so we were very opportunistic in how we brought people together. And so when you think about the kinds of roles that we identified, there's potential bias for certain in terms of those roles that we highlighted, and maybe we missed others that you all think would be key to include such an ecosystem. We didn't validate any of the trust attributes. So these were the recommendations that we have much more through discussion-based, so I guess you could say theoretical. So we haven't prospectively assessed how they're used in practice in order to understand or to say anything in terms of empirically these recommendations are having, what effect that these are having. And so there's certainly, I think, future work on how to define the methods that would be used to put to design and put into effect some of the recommendations that we've laid out, and to what degree can we measure any effects that they have on trust for multiple end users. So I'm excited to hear that CDS Connect reviewed the recommendations that we have and that we developed and have decided to move forward on those recommendations and putting them into place within CDS Connect. And so I encourage you to check out the MITRE's and CDS Connect's workgroup webpage. You can see in more detail what they were reviewing and plans for operationalizing these recommendations. Along those lines, I should attribute this slide to CDS Connect and what they're doing in putting the recommendations to work. So based on the CFWG's efforts, they've placed resources around enabling more robust search capabilities, thought about and considering ways to update metadata definitions, create tooltips and API notes, implement new process and metadata field to convey author disclosures like conflict of interest, and expanding the repository user accounts to enable aspects of notifications and feedback. So in conclusion, I think for someone like myself who didn't have the background that Dr. Platt has, this was a really exciting and interesting way to come to computable biomedical knowledge and clinical decision support, and understanding that trust is essential really for the sustainability of shareable CDS within an ecosystem, and that trust to my mind, I think this. I think we all agree that this was really maybe a first attempt at explicitly addressing trust within a distributed ecosystem like for clinical decision support. And so rather than trust being an emergent property that comes out of an ecosystem, trying to think ahead of time and make recommendations as to how could we promote trust within such an ecosystem. So we also believe considering actors and their relationships to inform matters of trust within the CDS ecosystem provided a really interesting way of being able to draw out different assumptions and of what makes for effective knowledge and how to share that knowledge. So what a knowledge author might think is important, a provider may not, and vice versa. We think that these recommendations, the trust attributes, they're not end-all and be-all, and see this as a starting point, and that for those that are looking to, or as the CDS ecosystem evolves, or how people think about employing learning health systems, how does I think the recommendations and the trust attributes can provide us a base point to start talking about and about trust and thinking about ways in which trust for knowledge and knowledge artifacts can be put into play across organizations. So we think that's it for this. I'm certainly happy to take any questions. That's my personal account. That's actually jrichardson@rti.org. Apologize for that. We could put that in the chat. And then also encourage you to check us out on pccds-ln.org to see that you can access the white paper there and see other resources and materials that and updates that we make. So thank you all very much. It's been great. It looks like we still have some time here for Q&A, and happy to take any questions. And Jody, maybe you could join in the Q&A and see if there are any issues, any opportunities to join in.
Yeah, we actually did get a couple of questions while you were talking, so I think we can start with those. You can hear me. So yeah, we have two questions. The first one is from Philip Walker, who asked whether we're utilizing the traditional information resources, i.e. literature, for the knowledge artifacts, or is there a potential for knowledge generated and vetted from HIEs and other LHSs, learning health systems?
Yeah, thanks, Philip. So the assumption that we had for this work group was that the starting point was a narrative guideline, and a trust would started from there, and then the translation moved from.
Yeah.
Go back to this is kind of a weird function. Yeah, so that was our assumption going in. But what you laid out, I think, is something that's that many people are considering and looking at, and that is how do you start with machine readable evidence from the outset? And there are some is what I think you're getting at, and in which case there are two activities going on right now. One is CPGs on fire, and another is EBM on fire, which is beginning to think about how to structure from the outset biomedical knowledge so that it can be more easily shared among players within an ecosystem. And I think to the MCBK community, also thinking about what are the types of metadata that would be or need to be included to make machine readable evidence from the outset. Oh, I'd also point out the work that Maria Michaels has been leading out of CDC as part of CPG on fire, but she's been leading a number of efforts around thinking how to embed or machine readable or interpretable data within any guideline from the outset, so that you kind of have mitigate some of the effort that goes into translating human readable text into logic and then something that's more implementable within a machine. I hope I answered your question.
Phil, do you have anything to add, or we can unmute? I think you're unmuted. You want to? Oh, yes, thank you. Yeah, and I think that's an important, it'll be an interesting question for MCBK moving forward also. So, and related to metadata, Rachel Richardson has a question sort of about metadata, but other things as well. But she asks whether you have recommendations or thoughts on who might be applying the trust-related metadata to CDS artifacts. So are they the knowledge authors, the implementers, et cetera? And what would be the burden on some of the trust-related metadata that could be automatically generated?
Thanks, and hi, Rachel. Great question. So I think our first example is laid out as the CDS Connect and putting them. So I think putting the metadata in effect to a degree. So I think they would be much more expert in laying out what have been the challenges as they've seen it so far. I guess I can. From our conversations in theory, I don't know if, Jody, correct me if I'm wrong, if we ever really got to that level of what's the an appropriate amount, or what's too much metadata, or what's not enough, and how would whatever trust metadata be captured within an artifact and be tracked and shared as it gets shared across stakeholders over time. One idea that we have been throwing about is the idea of a product information label for clinical decision support, and having with that CDS artifact a dashboard, if you will, of some kind that has a numerical rating or a star rating of around some of around the attributes that we laid out today. Jody, were there other aspects of what Rachel was asking about you recall from our discussions or the white paper that might apply?
Let's see. So I think you highlighted some of the issues when you were going through the application of the analytic frameworks, or the implications in the discussion section, and sort of which actors might be most impacted by each of these different things. I think it was hard to reduce the number of recommendations as it was. And we didn't really get to that level, but in trying to make them at least somewhat actionable, there was a sense that someone could take some ownership of different pieces of it. And there is the question of sort of what goes in the metadata and what gets expressed in other things, whether it's the governance or other sort of processes within the ecosystem. So that was sort of identified, I think, as the next step. And maybe something that MCBK can also sort of begin to think about.
Yeah, I think these are issues that the standards group for MCBK is interested in looking at these metadata. And as we're doing that, I just want to really commend both of you and the entire patient-centered CDS learning network and others that developed this trust framework, because you've just conceptually laid out all these components so easily and all the metadata that would be helpful to build this ecosystem that it almost seems easy to move forward. So it'll be interesting to sort of take this to the next level.
Yeah, I think it's pretty exciting. Are there any other questions? Mary Jo, I think you can start to give me access to the PowerPoint now. But as she's doing that, if there are any sort of final thoughts or questions, I can just sort of scroll through the participants. And I know many of you are involved in MCBK, or maybe new, or even were involved in this work as well.
This is Andrew Williams at Tufts. Forgive me if I may have missed one of the attributes. There was quite a bit covered. It's very exciting work. There were a couple things I was expecting to see that I didn't, and just so consistency, as it was defined, I didn't capture a couple of things I was expecting to see, one of which was the consistency of different guidelines with one another, or artifacts from guidelines with one another as one aspect of consistency that might affect trust. Another being consistency with the mental models of the people who are going to be implementing them.
Mm-hmm.
And well, maybe I'll leave it there. I had another comment as well, but there isn't much time. So did I miss?
Yeah.
So were those captured elsewhere, or were those parts of things that came up or are relevant?
I think that's a really interesting point. I think we were looking at consistency in terms of at the artifact level, and does it generate consistent, reliable results? What you're raising, particularly around the mental models of implementers, I think is really, I'd love to maybe think about that more. I think that's one of the great things of at least having done this really kind of kickoff work, is that there's a lot more that we could and maybe should factor, and so I think this is going to evolve. But I don't think we addressed the mental models of those who implement, and that is certainly a barrier, I think, traditionally among moving evidence from kind of the development point of a guideline to actually how it's put into practice, and those are two very different worlds. And sometimes there's zero shared mental model between the librarian and or whomever analyst that develops a CPG and the person who's actually expected to put it in, develop the logic out of it, make it machine interpretable, and implement it within the EHR.
And just to make a case for the other piece of consistency there, I think it's not uncommon, and there's a fairly good research literature showing that when there are very inconsistent guidelines, that's a significant barrier to trust in any one of them. So something that connects an artifact to its relationship to the total amount of evidence in a given domain, if there are several different and mutually incompatible breast cancer screening guidelines at a given point in time, for example, it creates barriers to trust. And a final point, I guess I'll stretch your patience with me and say the applicability of a guideline to the particular patient that one is seeing is something I'm familiar with having an impact on trust as well, that there's often suspicion from the provider's point of view that a given guideline actually is pertinent to the patients that they're seeing or at an institution. So.
Yeah.
But again, thank you so much. This is a fantastic presentation and really great work.
Yeah, thank you for those comments. And I think, some of that came up also in the evidence-based sort of part of what we were talking about. There's one final question. So I'll just say that the end of the webinar is an invitation to participate more in the Trust and Policy Working Group, which meets on Thursdays about every other week at 9 a.m. Eastern Time, and just go ahead and email me if you'd like to be a part of that group. And I'll give Josh, there's one final question about the relationship between trust and regulation. If you want to take that on, I'll go and just post my contact information at the end, and we'll just wrap it up there.
Sure, and thanks, Philip. Boy, I almost how trust is embedded within regulations. I almost want to hand it back to you, Jody, because trust is really right. This is really your area of expertise, and so how that gets embedded within trust. I think, to my newbie mind, that it's about consistency. And it's about doing fairness, so that there aren't some requirements on one group that are but different requirements for another group in order to share knowledge. Some of that could be what is the pay model, for example, and so how do you sustain a knowledge artifact so that it's updatable and reliably implemented, shared, and used, but one that's done equitably. So those are two things to my mind that I think how regulation and trust play out. But I defer to Jody. This is your...
I think that's a great answer. Part of it is also sometimes regulation can sort of reduce the risk of a intervention or something that's happening. So, and when there's less risk, it's easier to trust if you need to trust at all. So in a context that's very safe, there's not much at risk, and so trust is easy to gain. And so regulation certainly has a role, but when it becomes overburdensome, then it becomes a barrier to sort of effective communication and relationships. So there's, they are related, and there's a balance of the two. All right, well, this has been a fabulous discussion. Thank you, Josh. And again, just sort of a note up here, we have our work group calls about every 2 weeks. We are also, there's a role for people to help in sort of analysis, synthesis, and leadership within the group. We're currently developing a call for comment on issues of governance and marketplace and sort of the ethical, legal, social issues, as well as trust, that we'll be issuing probably in the next few weeks, by maybe this time in May, and hopefully you'll be able to help us spread that call for comment to your colleagues, but also respond yourselves. I think we'd like to see some, good participation there, so we can come up with some action items for moving this work forward. But also, there's a lot of work in this area being done, and we'd like to be able to use that in ways that can help all of us as a community, both within MCBK and our home institutions. So, all right. Any other? I think with that it's 12:01, and we'll call it a day. Thank you again.